Hello, I'm Dr. Steve Kariya. I am the new host of Housecalls. I took over from Dr. David Doman, whose work I greatly admired, and I'm happy to be the new host for this program. I'm also in private practice in pulmonary medicine in Kensington, but I look forward to working with you and all of the staff here in exploring new areas of health within Montgomery County. Tonight, I have a special privilege of introducing you to Mark Foraker and Lauri Harkins. Mark is the CEO of Mercy Health Clinic, and Lauri is the clinical director of Mercy Health Clinic. And they're here to tell us about the wonderful work going on for healthcare for underprivileged and underinsured persons within our community. So please stay tuned. Welcome back. So again, I have the privilege tonight of two guests, Mark Foraker, who's the CEO of Mercy Health Clinic, and Lauri Harkins, who's the clinical director of Mercy Health Clinic. So I think the first question is for you, Mark. Let's start off by telling us about the focus of the work that's being done at Mercy Health Clinic and the issues that you're helping us deal with within the community within Montgomery County.
Certainly. So the core focus of our work is serving uninsured residents, specifically in the county. Our organization saw our first patients on October 3rd of the year 2000. We recently marked 25 years of service. And although the clinic has grown and adapted over time, the core focus of our work is really not just focusing on uninsured residents, but addressing cost as a barrier to healthcare is something that is still critical to our work today. When we were founded, we were started by Our Lady of Mercy Parish as an all-volunteer free clinic. And we were started also as an independent, nonprofit, non-sectarian organization. And as we've grown over the years, we're balanced between paid staff and volunteers. But still, those core principles that we were founded on of addressing cost as a barrier to healthcare drive us today, and we still do not charge our patients for care. In the program that we participate in is a public-private partnership, and it's called Montgomery Cares. And with that program, we partner with Montgomery County, and it gives us resources to serve patients with no access to healthcare. So about 98% of our patients are completely uninsured.
So that sounds like great work. How great is the need within Montgomery County, and how many people are there in our county who are uninsured?
So we're estimating that it could be up to 50,000 people just in Montgomery County alone that are uninsured. The program serves right now probably about 27,000 adults that are in the program, and I believe another, say approximately 5,000 or 6,000, maybe a little short on that number with kids, adolescents, and through the pediatric program, Care for Kids. And when you look at the number of visits that those patients in the county accumulate across all the clinics that are doing work similar to ours, that number right now is probably coming out close to 80 to 85,000 visits that they're getting all through this program. Now, as you're hearing through the news and changes in policy, there could be a significant increase of uninsured in the county, including estimating potentially another 3,000 becoming uninsured who have Medicaid currently, just in this next year. And then we're unsure of those with private plans. So the number's pretty significant, just focusing on the county, looking of at least 50,000 people that have no health insurance.
So you mentioned something about Montgomery Cares and Care for Kids programs. Could you tell us a little bit more about those programs and how they work, and how is that different from insurance?
So we're fortunate. We live in a great area, and the county invests heavily in making sure that they're providing equitable care and services for all residents. And the Department of Health and Human Services in Montgomery County has prioritized and focused on looking at population health. And with that, in order to really, truly achieve solid outcomes, you need to make sure that all people in the county are addressed, taken care of, and have access to high quality health care. So how the county's gone about that is the program's been around for a very long time. I think it's been formal for almost 20 years, and it's called Montgomery Cares. So the county, Montgomery County, invests funds to support this program and sets policy and helps and provides resources. The Primary Care Coalition is another organization. There's really, I would look at this as 3 separate groups or entities. The county, like I mentioned, being those that set policy, funds, and resources. The Primary Care Coalition, which is really a foundational and support organization that helps prop all of us up from administrative and policy standpoint, also providing in-kind support services and allowing the clinics to focus on direct service and patient care. And then right now there's 13 health centers that are serving those 27,000 individuals I mentioned, all within a certain set of standards, and we have to meet certain quality metrics and requirements. And all of us carry out the work in a slightly different way. But it's these 13 organizations that work collaboratively to serve that patient population. And in our region, there are similar services, such as the Alliance in DC. But when you go throughout the country, this is a unique program. And we are really fortunate to have a resource like this and a local government that's committing to it. This isn't even in every county in the state of Maryland.
So, and please, Ms. Harkins, please feel free to join in. How do patients join such programs?
Well, the patients hear about the programs. Most of them hear word of mouth from other people. They're referred from the hospital emergency rooms, or in the case of Care for Kids, they are referred to or assigned to our clinic in their schools. So our patients have to be in the age range of 13 and older. They have to live at under 250% of the federal poverty level. They come to our clinic. They are screened for eligibility, and then they will become and see the providers.
There are financial as well as locational restrictions?
Yes, they also have to be Montgomery County residents in order to qualify.
Can you expand on the patients in the programs? In addition to lacking access to insurance, what other challenges do they face when we're trying to help people who have, say, diabetes or high blood pressure? And do they live in specific areas of the county?
Yeah, so to give a picture of what our patients are encountering in addition to being uninsured. So an individual, to qualify 100% of federal poverty right now is about $15,500 for an individual. I think the cap for the 250% in our program is about $36,000, a little over that. So poverty impacts everything. We have a fairly high percentage of patients that are managing diabetes. And so for instance, they're working with, we are also recognized as a patient-centered medical home. So we very much are not just working and trying to provide urgent care. We're working with our patients to really implementing all best practices possible, despite working with a patient population that has limited resources on their own. So we do work with them on nutrition education and lifestyle changes and make links to other organizations in the community. such as programs that are actually partnering with us directly. We have a program with Adventist Healthcare doing a food as medicine program. Also another organization called Community Farm Share with a similar program where those patients are able to acquire food during the growing season weekly, and then working with our nutritionists to make sure that they know how to use it. And we're measuring those lifestyle changes. So we integrate, knowing that our patients are also struggling with poverty, we integrate that into every aspect of our work. We also dispense medications directly on site through our pharmacy program. About 64% of our patients are leaving our program, leaving a visit with those medications free of charge. And we commit to that, knowing that that this resource struggle, that a flat tire could be something that's catastrophic for their family in terms of getting in the way of employment, of them being a good parent that's taking their children from place to place and school included, and knowing that anything we can do to help prop them up is essential to them. So when we're looking at it as a healthcare provider, we have that deep commitment to their health, but also acknowledging that we have to go beyond just that doctor's visit.
So if all of the patients are living within the poverty range for income, how do they pay for these services?
Well, we do not charge them at Mercy for their visits. So that often they'll make a donation for the services, but we do not charge them. And as Mark mentioned, we provide their medications free of charge. We keep a small pharmacy on the premises with generic medications. And then we also partner with MedBank, which is a program also put together by the Patient Care Coalition.
Yeah, the Primary Care Coalition manages that program with resources from the county as well.
Yeah. So and what the MedBank does is it's kind of like the Common App for college applications. They partner with us, and each drug company has a patient assistance program which will give medications for no charge to patients who qualify. But each drug company is different, each application is different. So it would be overwhelming for a clinic to try to manage all of the different drug companies. So the MedBank does that for us. We send them an application, and then they kind of handle it from there.
And so the patients making that contribution voluntary, in order to commit to that in our mission, that there's a challenge. I mean, we do a lot of fundraising. When I mentioned the partnership with the county, we do get a reimbursement. It's a flat rate, but that's for everything we provide. I mean, contractually, when we're participating in this program, we're contracted to dispense medications, to have a staff member who navigates our patients to try to find free or significantly reduced specialty care. As I mentioned, we're a quality of care system. So we're screening patients for cancer and taking on patients with really complex cases, diabetes and hypertension. It's a population that has a numerous stacked complications. And in order to offset that and commit to that mission, we have to fundraise the rest. So that amount that we get from the county is a tremendous benefit and resource for us. But in order to do that, we're not just providing a visit with the patient and they go on their way. We're tracking them, seeing when they're due for the next follow-up appointment. Those that are managing chronic health conditions, we are going through lists on a regular basis to see if they're due for follow-up screenings and when they're due for their next appointment. There's a lot of hands-on work for us to get the health outcomes that we achieve. So it is that balance of the earned revenue we get. We still have to fundraise usually about 51 to 53% of our operating budget every year.
So that sounds like a big financial challenge, in addition to all the logistical problems that you may have in terms of meeting your patients' population needs. So what are the other challenges that there may be in terms of trying to help all of these clinic patients that you're seeing?
Yeah, so that everything we see with the change in the world around us impacts us as well. As supply chain costs go up, we're impacted by that too. I mean, we also have to carry malpractice insurance. And as we're seeing the complexity of cases, I mean, it's everything from costs to shortages in supplies, to the fact that when our patients are afraid to seek care, they come to us sicker. In reality, they come to us with more complicated conditions. Conditions that are that we often have to take multiple steps, in some ways looking at ourselves as social service providers, as caseworkers, before we can become doctors at the clinic. And so a lot of that does add to the complexity of what we do.
So I hate to stop you there, but we do have to stop for a short break, and we'll be right back. Welcome back. I'm Dr. Steve Kariya, the host of Housecalls, and I'm here with Mark Foraker, the CEO of Mercy Health Clinic, and Lauri Harkins, the clinical director of Mercy Health Clinic. We're talking about healthcare access for the underinsured. So earlier, you had mentioned that you were receiving patients after emergency room visits or hospitalizations. So unnecessary hospitalizations are a huge drain on the healthcare systems and very expensive. Can you tell me a little bit more about the uninsured patients referred to the program after hospitalization and the work done to help them with these expenses and the healthcare that they need afterward?
Sure. One of our biggest goals in the clinic is to prevent emergency room visits, and that's something we stress with all of our volunteer providers and staff, because that can be devastating to a patient, the cost of an ER visit. But at times they have to go, or they go before they become a Mercy Health Clinic patient. Often it'll be, a 38, 40-year-old person. They go to the ER with vague complaints, abdominal pain. And while they're there, they are diagnosed with a major illness. One patient that comes to mind went to the emergency room with abdominal pain. He was seen, evaluated, and found to have uncontrolled diabetes, which he was unaware that he had, as well as high blood pressure. So he, they have worked him up in the ER, they gave him fluids, they bring down his blood sugar, and they discharge him with some medications, some insulin, some oral medications. They give him about 30 days worth and send him out, tell him to, meet with a primary care provider. And they often give them ideas of which clinics to go to. So we'll get the patient. Hopefully we get the patient. Often I'll get a call from the hospital saying we're going to send this patient over. Other times we don't get that. We like to get them quickly before they run out of their 30-day supply of medications. So they'll see one of our providers who will evaluate them. Often the medications that are given, prescribed in the ER or the hospital, are not affordable for the patient. So we'll make adjustments, give them what we have, and help them to apply for other medications through MedBank if they do qualify for that.
And you're also trying to teach people who may not be that versed in such skills diabetic calorie counting and what's a carbohydrate versus other things. And often you're trying to do this in a different language. Is that right?
Yes, it can be quite a challenge. We do have interpreters at Mercy, so that is very helpful, although each appointment does last a bit longer because you're saying everything twice. But we are very fortunate to have volunteer nutritionists who will work with our patients on their diet and exercise. We have a volunteer ophthalmologist who will see our patients, especially the diabetics, to look for diabetic retinal disease. We have volunteer pharmacists who will meet with them if they have a complicated medical regimen. So we're very lucky with the support system that we have and are able to provide for the patients.
I know that Mercy uses volunteer doctors. How does that work? And how does one become a volunteer physician at Mercy Health Clinic?
Yeah, so that gets tricky sometimes, but we have a wonderful group of volunteers. I think we're around 34 or so. And we have a mixture of physicians, physician assistants, and nurse practitioners from family medicine, internal medicine, to a multitude of specialties. And most of them hear about us, again, through word of mouth. And they hear from their colleagues that have come and really enjoy working and being able to see patients without all of the complications that you find in private practice of reimbursement and time constraints. We have them come in, they take a tour of the clinic. We tell them, what our mission is and what our constraints are, and can't think of any of them that have walked out and said, "No, I don't want to do it."
And they have to go through a vetting or licensing program with Mercy.
Yes.
They then have to take out or apply for a volunteer medical license that allows them to practice within this voluntary program. Is that right?
Yes, they have their own medical license for the state of Maryland, but Mercy covers their volunteer malpractice insurance, which is less expensive and much different than your regular malpractice insurance.
And are most of the physicians retired or yes?
Yes, but we also have some that are FDA employees who would like to get more clinical experience or clinical, see patients to not lose their clinical expertise. And we also have some that are working full time and still want to give back and see patients. And then also some that are moms that are at home and want to continue working, but not full time.
Can you give me an example of how this work that you do and how the work in general by the clinic has helped people within our community?
Well, yeah, I think on a day-to-day basis, we have such great stories of success with our patients. We do screening mammograms and pap smears for our patients at no charge and find, a lot of pathology when we're doing that. So, we might have a breast cancer, the person comes in for a screening mammogram and it's noted, an abnormality is noted. We can sign them up for a program through the state of Maryland called the Breast and Cervical Cancer Detection and Treatment Group, and they will pay for the patient to have a breast biopsy. If that biopsy is positive, then they will also cover the treatment, whether it's surgery, chemotherapy. I have a patient that I saw last week who went through the surgery, went through chemotherapy, and I just brought her in to give her approval to go get her breast reconstruction surgery. So that saved her life. She was only 38 when the cancer was found.
Now, are most of the patients in the program not working, Are they working? How are they supporting themselves?
The vast majority are working. I think you said what percent?
96% hold at least one job. So that's 96% of our patient population, terms used to hear in the past, the working poor. When you look at, you had asked earlier where these patients live. So for Mercy, most of them live and work in the Gaithersburg, Germantown area. When we look at their criteria, the income that they qualify for, they're earning, paying taxes, paying back into the community about $43 million last year.
So this is not a freeloading population by any stretch of the imagination. These are hardworking people who just have jobs where healthcare is not part of their benefits. Is that correct?
Correct.
And are still below the poverty line.
Correct.
Yes.
So this is a tremendous difference that you're making. Now, one of the other things that you mentioned, medications, they can be very expensive. How many of the patients receive medications from Mercy? And are there limitations on the medications that you can provide?
Well, I'll let you answer the how many are getting it. I can answer the second part.
So it's about 64% of our patients that we see each year, plus minus about 64%, get medications directly from us.
Mm-hmm. And we do have limitations on what we can provide. We use, as I said, we have our own pharmacy with the generic medications. We use MedBank to go through the drug companies to get medications, but different drug companies have different requirements for whether they're going to distribute those medications to a patient. So we also go through GoodRx, which I think a lot of people have heard about, that you can take a coupon to the pharmacy, also for generics that will lower the cost of a medication. But it can be very frustrating because often we know that there are really good medications out there that can treat a patient, that could help their condition, but it's just not available to the patient. So that's a big frustration that we have.
So I think you mentioned that you have volunteers at all levels. Can you tell me where your needs are greatest and how people can volunteer for programs like this?
Yeah, we have volunteer providers. We have volunteers who work in our pharmacy. We have FDA volunteers who come in and they help keep our pharmacy running. We couldn't do it without them. So I think we're always looking for specialists, especially. So we have, right now we have nephrology, we have ophthalmology, we have cardiology. I think and many others, I think where what we could really use is we need more ophthalmologists and more
endocrinologists?
Dermatology and gynecology were two that we're pushing.
Yes, those are yes. So those are big ones. Definitely gynecology. We're able to provide colposcopies for our patients in the office, which is a huge benefit to our patients. If you have an abnormal pap smear, you need to have a colposcopy done. It can all be done in the clinic, and they don't have to leave the clinic unless there's more abnormalities that are found and they need more treatment. So.
Now, I hope you have on some of the slides that will be introduced how people at home can become involved in the work that you're doing and the kinds of needs that you have: translators, clerical workers to process patients, pharmacists, mm-hmm. nurses, physicians, nurse practitioners, physician's assistants, volunteers who can help drum up some money for you. I think all of those are needs that I'm hearing that you might be very welcome for people who want to volunteer and give time to this very worthy cause.
Yeah, absolutely.
Are there other areas that I missed that you can think of?
I mean, as we've touched on, the need is tremendous, and we've seen our own demand for services in the last year has spiked tremendously. When just looking at our data closing out 2025, we saw approximately 2,000 more patient visits last year than the year prior. So you touched on it. I mean, really, volunteers, people helping us meet that need, fundraising, all of that is important for us to do this work in the way that we know it is effective. We have a small staff of about 22 people, only 10 are full-time, and we have 150 volunteers that make that happen. And we're constantly needing, as demand grows and the issues become more complex, we need more people to help us carry out this work.
Well, this sounds like great work. So I want to thank you both very much, Mark Foraker and Lauri Harkins of Mercy Health Clinic, for educating us about the great work that you're doing at Mercy Health Clinic. I hope you'll stay tuned for our next segment, which will feature Dr. Peter Sabia talking about updates for cardiology. So thank you very much for watching, and we hope to hear from you soon. Take care. Bye-bye.